Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Feel free to ask questions in the chat box as we go along, and your questions will be addressed. It is my pleasure and honor to introduce today's session host, Dr. Gurpreet Kaur Saini. She is a board-certified internal medicine physician and a distinguished alumna of the Yerevan State Medical University, where she graduated at the top of her class. Dr. Saini completed her internal medicine residency at MedStar Franklin Square Hospital, earning the prestigious Primary Care Star Award for her outstanding patient-centered care. In addition to her clinical work, Dr. Saini has made meaningful contributions to medical research and also education. As a researcher at the National Institutes of Health, she has advanced our understanding of the neural mechanisms behind decision-making and addiction. Currently, she serves as the facility medical director at MedStar Medical Group, and she applies her leadership skills to improve patient care quality, operational efficiency, and she also explores the integration of innovative technologies like AI into primary care. Dr. Saini also actively shapes the medical profession through her editorial work and peer review roles, as well as her involvement with professional organizations. She serves as the co-chair of the Volunteerism Committee for the American College of Physicians, the ACP, and actively supports the American Medical Women's Association, AMWA, AMWA, and is a member of Sigma Chi, which is the Scientific Research Honor Society. And this really demonstrates Dr. Saini's genuine commitment to service, mentorship, and also professional development. And what truly sets Dr. Saini apart is her ability to connect with a very diverse patient population. She speaks 5 languages fluently: Armenian, Russian, English, Punjabi, and Hindi. That enables her to really foster trust and rapport with patients and colleagues from many different cultural backgrounds. And this global perspective, combined with her clinical expertise and leadership, makes Dr. Saini a truly exemplary figure in medicine. So please join me in welcoming Dr. Saini. Dr. Saini, feel free to take it away. Thank you so much.
Hey, thank you, Minayal. I really appreciate your introduction. I must tell everybody that I'm really, really pleased and I'm very thankful for you guys to let me come and talk on teleshadowing. It's a unique opportunity, not only for students, but for me as well as a speaker. I must share that early on into my medical career, almost like everybody who is listening to this as a medical student right now, either sitting in India or anywhere internationally, probably has a dream to either come to US and do their residency, or maybe go to UK or Australia, wherever life leads them. But I must tell you, don't lose hope at all. I think if my journey can say one thing, that's for sure, not losing hope and just persevere and be as hardworking as possible. I started my medicine career way before, but when I was in India, I grew up in Punjab in Ludhiana, and I was a valedictorian from my school as well. Then I went into my medical studies for Yerevan State Medical University. I studied there for 9 years total and finished my MD. I went back to India and I practiced there. I gave the licensing exam for India as well. But I very early on knew that I want to pursue my medical career here in US. And I started studying for USMLE exams and stuff. And slowly, little by little, when you persevere, you do hard work along with your work. While I was working in India, I was able to take my step one, and then I took all other steps here in US, and I pursued my career in research at NIH in the drug addiction. So, and eventually I got into the residency. So anyone who is listening to this, I'm very happy to answer any of your questions, but please make sure if you want to come to US or you want to pursue your career anywhere outside India, Nepal, Pakistan, you need to work hard. These countries pay you back a lot. You will succeed here for sure. You will get amazing mentors during your life in your medical career here. They will guide you in all the directions. And, for these countries, I must say, sky is a limit. But you need to be as hardworking as possible, as just like Minahil. Okay, so we should now start with our presentation. I actually choose the topic for internal medicine standpoint about hypertension, but at the same time, in my clinic where I see my patients daily, I ask questions about hypertension from my patients, but I get one question very oftenly from my patients. I'm developing blood pressure. I'm 40, I'm 45 or 50. How can I prevent this? So some of our slides today going to go over prevention on hypertension, but it is also about, you know, what hypertension is and what are the take-ons from this PowerPoint you guys can get. Let's move on to this. So I have here the definition for hypertension. Normal blood pressure now is actually anything systolic less than 120 and diastolic less than 80. And according to the New England Journal of Medicine and JAMA, the definition for hypertension got changed at least a few years back. And now elevated blood pressure is anything with the systolic range of 120 to 129 and a diastolic of less than 80. And hypertension class 1 or stage 1 is blood pressure 130 to 139 and a diastolic of 80 to 89. And for stage 2, it's a blood pressure 140 and above, and diastolic is 90. So that basically comprises what hypertension is. And you will see a lot of patients in the primary care, wherever you're practicing, wherever you're seeing patients, even during your medical school, you will see patients who are routinely coming to your OPDs or your outpatient clinics, and their blood pressure is ranging in 140s or 135, high 130s, high 140s. They are all actually technically now have hypertension. Let's move on to the next point. In the clinical practice, patients who are taking medications for blood pressure are usually defined as having hypertension, and we call that as a treated hypertension. A lot of times, my patients, even in my office, I see they will say to me, I'm going over their medications. They will say, no, I don't have a hypertension. And then you will see they're on amlodipine or losartan or lisinopril. You have to point out to the patients, yes, you do have hypertension. It's just that your blood pressure is not high because you are on medications. So that is a treated hypertension. We also see cases for white coat hypertension. Trust me, this is a phenomena. I see it quite often in my office. White coat hypertension is defined as a blood pressure which is consistently elevated when the patient come to you in the office. And the patient will relentlessly tell you whenever they're checking their blood pressure at home, it is always below 120, it is in hundreds or 110s. That's what is white coat hypertension. Some of us, not all of us, can get nervous when we are coming into the doctor's offices. And the way you differentiate white coat hypertension is, do you tell the patient, I understand what you are saying, give them reassurance, and move on to the next thing and say, let's do one thing, maintain a chart of your blood pressure readings from home. Then you bring it with your blood pressure device from home because, remember, blood pressure devices at home are not titrated. So you have to bring that into the office, then check it, look at that log, check the blood pressure device, and then take the blood pressure from the machine in the office and see if you can come to the point where you think it could be white coat hypertension. White coat hypertension is a syndrome whereby a patient is feeling anxious in a medical environment and it results in abnormally high reading for the blood pressure. In another way, we are actually making them nervous. Is there a reason your blood pressure should be so high? And the patient is saying, could the 2-hour wait in the waiting room be the relation? Maybe that's right. Sometimes my patients have to wait. Now, I also want to touch on something very important. You will listen your attendee saying or using a word hypertensive urgency versus emergency. Emergency is when the blood pressure, diastolic blood pressure is usually above 120. Now there is an evidence, for example, your patient went to the ER and the blood pressure is 200s over 110 or 120. And you did the blood work and the metabolic panel shows that the creatinine is example 2. That basically is an example that there is either an acute kidney injury, and that is because of the high blood pressure or underlying neurological symptoms like vision loss, or patient is saying, I'm having chest discomfort or chest pain. So anything, when you see a blood pressure that is high, but at the same time there is an end organ damage, let it be kidneys, neurological system, cardiovascular system, that we call as hypertensive emergency versus urgency, where there is no end organ damage. It's very important for you guys to have a clear concept of this right now, because you're going to get a lot of questions, even in your boards, in your day-to-day life about these two phenomena. The risk factors for hypertension, I listed here the personal factors could be gender, age, race, and family history, versus the factors that we can modify in a day-to-day life. Stress, yes, trust me, as a primary care physician, as an internist, I see people being stressed about multiple things and their blood pressure is skyrocketing. Smoking, because it causes inflammation, yes, it adds to hypertension. Excessive salt intake. Now, our diet these days is very high in the salt that is inadvertently added to the things. For example, even a small thing like a pizza dough, when you're making a pizza at home, has a salt added to it as a preservative. Chips is another example. Like pickles, there's salt added to these things. So sometimes patients will say, I don't take excessive salt. Then you have to say them, okay, take a step back. Are you eating a lot of processed food? So processed food is anything that is modern diet we have, where we're trying to save time and we're not cooking with our traditional methods. The processed food is very high in salt. Physical inactivity, sitting, is a modern day smoking. I have a patient, I'm going to give you an example. He's 35 years old, and his blood pressure, one day he came to my office to establish his care. His blood pressure was 190s. 35-year-old with a blood pressure of 190. He did not have any end organ damage or anything. However, I started asking him, how much do you walk? And he told me that he walk about, to his post box and so forth. I asked him, I was like, how about we start tracking on your watch or on your phone how much you're walking? You keep your watch next to you, and that tells me how much you're walking. He came after a month, and I reviewed the data with him. You guys would not even, you would be surprised listening to this. He walked about 500 to 600 steps daily only. Do you know how much physical inactivity that is? That probably tells me that he was spending 90% of his time either sitting on the couch, laying in his bed, and just being physically inactive. And his blood pressure was 190. These things are very important, because this is the time when you're going to talk to the patient and going to learn about what lifestyle things they are doing that is contributing to the hypertension. In this guy's case, I told him, my simple advice to him is, can you walk at least 1 mile a day, or can you walk at least 5,000 steps a day? I gave him a small target. I didn't want it to take him to 10,000 steps, because that would have been too much for him. Could it be that he's lazy? Maybe. I asked him to do the 5,000. He was not able to do 5,000. He came back in a month and he started walking 2,000 or 3,000 steps. And you know what? He was getting motivated by this. He was looking at his watch daily, and he was now understanding how much physically inactive he was. And by doing this simple exercise, I was able to bring his blood pressure without any medicines from 190 to 150. So that's a very important take home point. We always need to spend time with the patients, learn from what they are doing at home. That way you can treat them better. Then alcohol is another factor. And of course, obesity, which goes with physical inactivity and so forth. There are also causes of secondary hypertension. And once again, I see this quite often in my office. There are patients who will be taking, for example, Aleve, ibuprofen, or naproxen, and they're taking this just for arthritic pain every day at home, 250 to 500 milligram. And then they will come to you one day and they will say their blood pressure is 140 and 150. And then you start reviewing the medications. They will say, no, I don't take anything except multivitamin. And you ask, do you take naproxen? And they'll say, yes. Trust me, non-steroidal anti-inflammatories, they contribute to the hypertension. Decongestants, testosterone, which is a very common supplements in men that want to do the bodybuilding. Some of the, manufactured products for bodybuilding, the protein powders and stuff, they have testosterone added to that. So just be careful. Oral contraceptive pills, cocaine, amphetamines, they're all the causes of secondary hypertension. I also want to emphasize we are seeing an uptick in obstructive sleep apnea cases. People who have sleep apnea can have untreated hypertension and undiagnosed hypertension. So that's very important. And folks who have thyroid disease, especially high thyroid, and then adrenal gland tumors, some adenomas, of course, because of cortisol increase, can lead to hypertension. So why is blood pressure a problem? When blood pressure is elevated, blood vessels are working a lot harder. You know that, right? Your vascular tone is much more harder, and heart, which is a pumping organ, now has to work more harder to maintain the body's function at the same level. When blood vessels are constantly working much harder, there is an increased risk of many chronic health conditions. These conditions include stroke, coronary heart disease, heart failure, and chronic kidney disease. Complications for hypertension, stroke for central nervous system, hypertensive emergency, when I was telling you guys about that, can easily lead into stroke. When a patient's blood pressure, without knowing him, is in 200s, one day, boom, they will have, for example, a sudden loss of vision, or they will say, I was mumbling some words in the morning when I woke up, or I was not able to feel the left or right side of my face. Again, signs of transient ischemic attack. Heart failure, sexual dysfunction, untreated hypertension can lead to heart disease, kidney disease, kidney failure, and vision loss. We call it as hypertensive retinopathy. Treatment for hypertension depends on the choice of agents. The first line agent still remains the calcium channel blockers, amlodipine. Be mindful if you start a patient on amlodipine a month or 2 months later, they come with an ankle edema. It is one of the side effects more commonly seen in women. Then, of course, diuretics and fluid pill. This is, I must emphasize, in my daily practice, I do not add my patients on Lasix or hydrochlorothiazide as a first line. My first line is still angiotensin converting enzyme inhibitors, such as lisinopril, benzapril, or angiotensin receptor blockers, such as losartan, beta blockers, such as metoprolol. And after that, either we start thinking about Lasix. You must know what is a treatment resistant hypertension. Whenever a patient is on, for example, 2 or 3 or 4 of the blood pressure pills, and on the top of that, one of them is a diuretic, let it be a hydrochlorothiazide or a Lasix, that is a resistant hypertension. We'll go about that. Next, this is just I just thought to add this as a cartoon. This should take care. The MD is saying this should take care of your blood pressure. It's a prescription for relaxed fit genes. But remember, once again, obesity can lead to hypertension. But there are several other factors too. I always believe, and I go by this virtue, that prevention is better than cure. If any of you guys are going to pursue internal medicine, primary care, you will realize this in your practice many years down the line, that it is very important to prevent certain things than just curing them. It will make your life and your patient's life easy. Yes, it is very easy for us to just hand over a pill to the patient and say, just take it. However, if you can avoid giving him that pill by changing things in their life, it will be much more beneficial for them, and it will add years to their life. In most cases, high blood pressure can easily be managed by making some healthy lifestyle choices. For example, reducing stress, exercising regularly, eating healthy diet that definitely has a lot of vegetables and fruits to that, losing weight, stopping smoking, cutting down on caffeine intake, and limiting alcohol. With the caffeine intake, I must add cutting down on the energy drinks. A lot of us, even in the med school, we were drinking that Red Bull, there are multiple energy supplements that you can buy over the counter here. But those Red Bulls and those energy shots, they are loaded actually with the substances that cause increase in the cortisol, and then in turn it leads to the high blood pressure if you keep following that habit, or you are taking this on routine basis. Walking itself, we know now, can bring your blood pressure by 10 or 20 points down if somebody is walking on a daily basis, and they do at least 1 to 2 miles of a walk. I see this on my routine practice. There will be patients that are only on a one blood pressure medication for past 10 to 15 years. And then you say, hey, Mr. John, what are you doing? I do not see that your blood pressure is ever high. You're only maintaining on, for example, a 5 milligram of amlodipine. What do you do on daily basis? Then Mr. John will reveal you, I finish my work and almost every day I walk 1 to 2 miles. That's very important. It's a very important caveat. So prevention, decreasing stress and mindfulness exercises, which is very important, stress management in our day-to-day life. Meditation, yes, it has proven that it can help combat the anxiety and stress and can decrease the blood pressure. Make sleep a priority. On an average, we should get at least 7 to 9 hours of sleep. I'm kind of an individual. If I haven't slept for 7 hours, my blood pressure in the morning probably is going to be high and I'm anxious. Engage in nature. There is a Japanese exercise. I'm lacking on the name of it. They have it is actually called as, I do not know the Japanese name, but I know it is called as a forest bathing. This exercise itself, they did a research on candidates who were doing daily outdoor walking, just being in the forest, only walking, absorbing the nature, and observing the nature itself decreases the stress. So again, go outdoors, go for a walk. Exercise, of course, is important for controlling your weight. We know that high intensity interval training is also beneficial in reducing blood pressure. But I was reading a recent journal paper that did a meta analysis, of course, on the benefits of exercise, but more on the benefits of walking. Now, the recommendation is if you're doing an exercise, it should be at least a 150 minutes exercise per week to help to lower the blood pressure of 4 to 5 mmHg. And it also is very important for heart health. The diet, as we talked about, the diet that is less in the processed food, less in the salt, can help decrease the blood pressure. Dietary approach, which is DASH diet, dietary approach to stop hypertension, is a very good caveat that you can always share with the patients. Pull up the information, tell them to avoid the food that are, very high in glycemic index. Complex carbohydrates are good. That includes the lentils, legumes, oats, and couscous and all those things. Diet that is rich in fresh fruits and vegetables definitely have to lower the blood pressure. Low protein is better. Low fat and dairy is better too. Other dietary interventions, fish oil, high fiber, kale, garlic is anti-inflammatory. We know there is a blueberry berries, purple sweet potatoes. These are all high rich source of antioxidants. Flax and chia, I'm sorry, flax and chia seeds, nuts, and alcohol, of course. I got this slide from, some of you might be aware, there was a research study going on. It's called as the blue zones. There are certain pockets in the world where scientists did research, and there were folks that were living past 1995 or up to 100, and they were very healthy when they were crossing the 85 to 90 years of age mark. And those are called blue zones. There's a blue zone somewhere in California in US. There's a blue zone in Japan, blue zone in Greece. And this is a book. I must tell you, and it's a documentary on Netflix as well, if you guys can find it. And maybe it is on YouTube too. That documentary actually goes on what these individuals are doing that is giving them a life at about 80 or 85 years of age where they do not have any chronic medical conditions, which in this day and age is high blood pressure and diabetes. If you don't have any of these two, I would say at least any of these two, you are already winning a prize in your life. And most of these individuals were eating diet that was very high in fish. They were consuming a lot of nuts, especially on the Greek coast, a lot of beans, peas, lentils. But at the same time, These individuals, these elderly folks, 80, 85, 90 years, were very physically active. They would walk almost everywhere. And trust me, when you look at this documentary, there's a village that they portrayed in Greece, and there are women in their 1995, healthy vision, everything good, no chronic medical conditions, and they're stitching. They're walking almost everywhere in the village, and the village is up on the hill. So these are actually the blue zone folks. We definitely need to learn from them how to live longer, but at the same time, a healthy lifestyle. Cut out on the junk food. Evidence shows that sugary drinks and foods that are linked to the high blood pressure. That also suggests that sugary drinks on a daily basis can increase your risk of high blood pressure. It's always about finding the right balance between the healthy and the unhealthy food. It, of course, can be challenging. Some of my patients, I can say, they're coming from very restrictive backgrounds, um, very challenged. Some of them do not even have money to afford the medications, and let alone I am telling them to buy foods, that are high, and they're expensive. So one thing you can tell them is avoid junk food or processed food and try to cook by yourself. Um, but it's much more cheaper for them to buy a junk food at a McDonald's than cooking for themselves. But it's always about educating them on a daily basis and gearing them toward healthy lifestyles. Small changes always goes a long way. Nobody expect anyone to leave a bad habit or change their diet overnight. It's going to take some time. So always educate your patient that if you're going to pick a healthy lifestyle or a healthy habit, you need to think like you're marrying with this thing. For example, if you cannot do exercise but you can do daily walking, you now need to see, can you do a daily walking almost every day for your rest of the life? Small changes are still much more better and they go a long way. Don't ask them to leave the things that they're doing. For example, even for smoking, I can tell you, I have patients who can go cold turkey in one night and quit smoking, but then there are others who still struggle to quit. So be patient with them. One major lifestyle change: smoking and blood pressure. We know smoking damages blood vessels and it causes inflammation and plaque formation. Of course, it increases chances of heart attack and stroke in patients with diabetes and hypertension. And smoking can harden the arteries, and it is much more harder for the blood to actually pump through them. That is the reason that it causes the blood pressure. And once again, now here we are. Can we learn something from the blue zones? I tell you to buy this book for the blue zones and, of course, look into this documentary. As I was saying, this blue zone is in Loma Linda, California, then Costa Rica. There's a village, Sardinia is a region in Italy. Ikaria is the village that I was talking about in the Greece, and Okinawa in Japan. These are the folks that are living at least a very meaningful, healthy life, and living above 95 plus 100 years of age. And we need to definitely learn from them. Blue zone inhabitants' longevity is partly attributed to their diet, along with other factors like their exercise and their social environment. Most blue zone diets are primarily plant based, very high in fruits and vegetables. And once again, these are diets that are very low on the animal products. Most of them eat healthy plant based foods that are rich in lentils and so forth. And they also maintain, the folks in Loma Linda, California, for example, they have a healthy social circle. They eat nuts. Most of them do not smoke. They have a constant moderate physical activity. See, just imagine you're in a village in Greece, and I did not saw on this documentary any gym in this village. These folks are not wearing very expensive athlete or peloton leggings and jumping on a peloton or going to a gym, driving to a gym, and so forth. As I said, most of them were in their 80s and 85s, and they asked them these questions: what did you did that you don't even have high blood pressure or diabetes? And most of them will tell you that they worked in their fields, they walked almost everywhere, and they just eat healthy. So having a gym membership is not that important. Just having a moderate physical activity daily is more important. Social engagement, um, and once again, lot of sunshine. They have habits like gardening. There is no time urgency in their concept. They ate diet that was free for alcohol. Most of them had a religion or a faith. They were geared toward a religion, and some of them also incorporated turmeric into their diet too. And that's about it. I'm thinking, just make sure if you guys have any of the questions, please definitely let me know. But I hope you guys can take some points from this and can incorporate into your med school, but at the same time into your long coming career for medicine.
Thank you so much, Dr. Saini. I know that was an incredibly informative session for me as well. I remember learning about white coat hypertension and all the challenges with the DASH diet and trying to implement, all these lifestyle modifications for patients and it's very challenging, especially when it's very expensive to buy healthier foods and it's cheaper, like you said, to buy like McDonald's.
Yeah.
So thank you so much for this incredibly informative session. We're now going to be hosting our Q&A session with our students. So the students sent in a bunch of questions. They're very interested. So first I'll ask questions regarding hypertension, and then we'll switch to questions about your life and your career journey leading up to internal medicine. So about hypertension, you talked a little bit about asking patients to increase their daily steps, right? So what other strategies do you use to help patients adhere to lifestyle modifications like the DASH diet or regular exercise?
I think I've done a few things. Number one, as I was giving you this example, every day in your medicine career as a primary care, you learn new things and you learn from your patients. And then you incorporate that slowly into your practice. And then you start making this as a habit. um as I was giving you example about this 35-year-old guy, um he and I said, and who in these primary care clinics, who has time to sit with the patient for 20 minutes and talk, hey, what do you do at your home? And then no, patients are not going to tell you that I'm sitting on my couch for
Mhm.
8 hours a day. They're not going to say that. You have to extract that information out from them. Sometimes I ask them, can you maintain a diary of your physical activity? Sometimes I ask them, go buy a watch, any watch you can find that is cheaper, fits your budget, and start tracking. Your Fitbit is a cheaper one. Start tracking your way, your steps. Sometimes I ask them, maintain a diary to start tracking your weight, how much I'm walking daily, and then you're tracking this with the weight. So I've done some ways where you are giving patients some homework. That way, they are also thinking that there is a challenge involved in maintaining their own health, and they are trying to take an ownership to this.
Mhm.
I think that method has worked a lot with me. So as I said once again, telling them go home, buy either a Fitbit, start tracking what they're eating in a day. Sometimes I ask them, there's a MyPal Fitness app that
Mhm.
they can download, and they can start logging in what they're eating in a daily basis. So those kinds of things have really worked.
Thank you so much for sharing. And you mentioned about like time to counsel patients as well, because do you normally feel like you have enough time to counsel your patients?
No,
Mm.
not really. I don't have enough time. I must tell you, um, that if I'm treating 10 patients out of hypertension, if I would have enough time in an ideal situation, in an ideal world, probably out of those 10 patients, I might be able to make more meaningful changes in their life, at least out of them five or six. But on an average basis, you have to extract the time. But no, we never have enough time to talk to them. And another thing is, these conversations could be very challenging. Number one, these conversations could be very uncomfortable for some patients. They might come to you and say, well, I'm not interested in walking that much. I think I look fine. Then there is this image, there is this challenge dealing with their body image. You have to be as non-judgmental with them, but polite. And at the same time, you want to come from a perspective where you're not talking down to them, but actually you're, you know, making a decision, talking with them. It's very important in a day-to-day practice in US. If any of the kids back home in India are listening, or Nepal and Pakistan are listening, You all know what I'm talking about. In our countries, physicians, especially doctors, I practiced in India for 2 years before I came to US. Um, Doctors actually talk. I must say, I apologize, but some of them do talk down to the patients, because patients are not taking ownerships in our countries for their health. But that approach doesn't work very well or mesh very well here. Over here, you have to be very polite with the patients, give them some homework to do, give them some realization about their health, and just be very gentle and polite to them while talking and explaining them their health. So there are a lot of challenges that we face in primary care, but yeah, there is not enough time.
Thank you so much, Dr. Saini. That's very unfortunate to hear. Number one, that you don't have enough time for patients. I can only imagine because of how our healthcare system is structured, and also the fact that I know that we learned this as well in our first year in medical school. Like talk at the level of the patient, even physically. Like try to get down to their level, eye level. Pull up a chair. Don't talk down at them. Even physically, like don't tower over the patient as well. In fact, a study has shown that. Physicians who actually sit down with their patients, patients saying that they have spent double the amount of time that they actually did with them, even just by sitting with them.
Yeah, that's very important. You need to pull the chair. Don't stand at your workstation if this is that meaningful, because then you're going to have that connection. Then patient really going to say, yes, physician. You're listening as a doctor when you enter into a patient room. We all
Mhm.
are listening, even if you stand at a workstation or you sit on a chair. But I feel like when you're sitting on a chair at their level, eye to eye, talking to them, they just have that bonding, that immediate connection. So I think that's very important.
Got it. Thank you so much, Dr. Saini. Another question that a student had was actually about antihypertensive medications. Like, how do you decide which antihypertensive medication to start with? We have ARBs, you have ACE inhibitors, beta blockers, especially in patients who have multiple comorbidities. So, how do you decide which medication to start with?
So let's just take on before comorbidity. Just for example, a patient only has hypertension, and let's just say he or she has a diabetes. We all know diabetes down the line, these patients probably can develop microalbuminuria. They will have albumin into their urine, that will be excreted if their diabetes is not controlled. Sometimes, um, in in an unideal world, the diabetes is a challenging condition to manage, and they will have microalbuminuria. So think about that ahead of the time and add lisinopril or losartan. These are my go-tos. Metoprolol also. Now comes the case of patients that have heart failure, for example, that have atrial fibrillation. They have something going on with the heart. Most of the cardiologists prefer to add metoprolol as the first line, then add on to the lisinopril or losartan. Amlodipine will be another one, but I rarely start hydrochlorothiazide or Lasix as a first line. Clonidine is getting obsolete. On the contrary, I had patients um, that were started on clonidine at least 15 or 20 years ago, have been taking clonidine since then, and now I'm slowly tapering. Remember, with clonidine, you have to taper it slowly. So I'm now starting to slowly taper it because we don't use it in the primary care practice. So the go-tos will be the ACE, the ARBs, the calcium channel blockers, and the beta blockers.
Got it. Thank you so much, Dr. Saini. That matched exactly what I learned for my board exams. So how often should patients with controlled hypertension be monitored in clinical practice?
So controlled hypertension is anybody coming to your office. They are either on one or two of the antihypertensive medications, and the blood pressure in the office is like anywhere in 110 to 120s. Those patients, I often bring them, and the kidney numbers, kidney function is fine. I will say I will bring them every 6 months. Um, and comparison to the somebody who does not have the blood pressure under control, that's a different scenario. But controlled ones, you can bring them every 6 months for a follow-up.
Thank you, Dr. Saini. And on the flip side, if a patient has a hypertensive emergency in the clinic, what are the immediate steps that you take when you're faced with a patient who has like an emergency like that?
So it depends on few things here. If the patient says with hypertensive emergency, you're checking the blood pressure is 210 over 110, and you ask the patient, do you have any chest pain? The answer is no. Do you have any blurry vision? No. Are you peeing normally? Are you peeing daily? Yes, I'm peeing. I'm daily. And you check the kidney numbers. If you have availability of checking a metabolic panel, the kidney function is fine. They do not have any end organ damage yet. Then yes, definitely say, okay, going to put you on a medication. Come back in 3 to 4 days or even a week, and get your blood pressure checked at home, maintain a log, and come back to me. If and always give them an advice that in case they develop any blurry vision, they start developing any chest pain or chest pressure, then definitely they have to go to the ER till the time you see them. Now, the another scenario is a patient saying to you, he's having blood pressure of 200, and then he will say, at least 2 days ago, I had a blood vision. Or they will say, I was having a garbled speech that was 2 days ago. It lasted only a few seconds, then it went away. Now, remember, patient does not know what their blood pressure at that time was. Some of them will not even check it. And trust me, I had a patient, he was 70 years old. This was a month ago. He wrote me on a patient portal message that, hey, Dr. Saini, I did not check my blood pressure, but 2 days ago, I experienced a garbled speech when I woke up. It lasted for a minute, then it went away. Now, this patient is 70, he has other comorbidities. Something that should come to your mind is something is going on, hypertensive emergency or a TIA. I end up sending him to the ER. His blood pressure was above 200s and he had a TIA. So, hypertensive emergency, if they are having a symptoms in your office, depending on your symptoms, blood vision, or if you're suspicious of a TIA, send them to the ER immediately. If they are currently asymptomatic, thank God that they have some time. Put them on a medication, bring them for a close follow-up.
Thank you, Dr. Saini. That was very helpful and good to know for my future practice. Thank you so much. Now we're going to switch gears into asking questions about your medical journey. So our first question from our students is, what inspired you to pursue and choose internal medicine over other specialties?
I think I am an anomaly in that case. I wanted to go into hematology, oncology, and I did all my rotations, even back home in India and in US, all in hematology, oncology during my residency. But you know what? During a second or third year of my residency, I started to feeling a burnout from that. The burnout is that patients don't get better. There's an emotional burnout with that practice. And I started to like the primary care side, the primary care, the office, clinical rotations during my residency at the same time. And I was like, this is something that I can do. Number one, the primary care has a option. Most of the primary cares these days have an option of working from Monday to Friday. It's 36 clinical hours and 4 hours of your admin time. And you can, depending on the practice where you join, you can choose how you're going to complete those 36 hours. Some folks in my office, even they only work 4 days a week. So that was also another thing. I wanted to have my weekends to be off. So that was a plus point in the primary care. And then the reason particularly I choose internal medicine is it is almost touch of everything. And that I see even in my day-to-day practice. I treat patients with rheumatoid arthritis. I treat patients with asthma flares, COPDs. I treat patients with psoriasis. I treat patients with dermatological issues. I do a little bit of a nephrology. So you get to do a little bit of everything, a little bit of a psychiatry. And always remember, in Maryland, it's very difficult now to get an appointment with specialists. Particularly, we are getting very big pushbacks from sending or referring patients to a neurology, psychiatry. So most of the challenging depression patients or anxiety patients, you're probably going to manage them on your own, and it's going to be 6 months, 8 months down the line that the patient going to get an appointment with a psychiatrist. Same for neurology. Nephrology, on an average, a wait is 1 to 2 months. So you are the one as a frontline internal medicine physician who has to manage these patients. So I think the biggest thing with the internal medicine for me to choose was it had touch of almost everything as compared to oncology, which was only geared for cancer medicine. That's why I choose the internal medicine.
Thank you so much, Dr. Singh. That was very helpful. I'm also interested in internal medicine, so I'm always interested in learning about, why people choose it. And there's always an option to do like a subspecialty later down the line, even
Yeah.
if life gets in the way. I guess my next question is you mentioned you talked a little bit about Maryland. As a state, I wanted to give everyone some context. Like Maryland has some more affluent areas, like wealthier areas near DC. And then there's also the eastern shore of Maryland, which is considered like a bit of a more rural area. So I know that you work right in the middle, like in between both places, like in Annapolis. That's the capital of Maryland, which is kind of in between the eastern shore and also the western areas. So can you talk a little bit more about like your rural patient population? I know you touched a little bit about how some can't really afford medications or food insecurity and access like that. Do you have rural patients in practice? And if so, like how is that different from treating patients who live in more affluent areas?
Oh yeah. I practiced for at the site on the Eastern Shore for 4 years as an internist. I must tell you, I was the only, and there were two internal medicine doctors, me and another one who was retiring at the time, in the area of 70 miles. So that's a, just put into perspective, that's a very big thing because and then around that time, COVID hit. There were a lot of my patients who could not see specialists for many, many, many months. ENT, pulmonology, dermatology, psychiatry. And the rural population on the Eastern Shore has a huge demand for primary care. Almost everybody in US needs a primary care. Even back home, they need primary care. That's different thing that they choose not to go to them. However, on the Eastern Shore, the need for primary care is very high. I had patients that were affluent, but at the same time, most of my patients were restricted on the factor for the money. They had challenging conditions at their home. There's a big population that has opiate addiction crisis here too. So you have to deal with those patient population too. You have to choose to refer these patients to pain management because they have been on chronically on narcotics just for chronic pain. Um, of course, a lot of psychiatry cases too, as well. But on the Eastern Shore, the medicine is much more challenging just because we do not have that many primary care physicians available. The patient population is quite different. Most of my patients are were farmers or they were, like in Britain, they will say chippy born and chippy raised. Most of them were born and brought up on Eastern Shore. Some of them don't even want to cross Bay Bridge. It's a big thing for them to even go to Annapolis. And then now that I work in Annapolis, I have a lot of patients still coming from Eastern Shore. Like as far as I can give you an example, I have one of my patients who comes from Tillman Island and another one comes from Cambridge, which is about 50, approximately 40 miles to from my practice. It's just because the providers, the primary care physicians, are so short to find, and there's just big, huge shortage for the primary care. So my patient population varied a lot, and I think that was the very challenging time. But at the same time, I felt very grateful when I was working on the Eastern Shore that I selected internal medicine. If I would not have selected internal medicine, I probably would not have had experience to deal with all the myriads of of the medicine itself and treat my patients who have dermatological conditions, who have psych conditions, they have chronic kidney disease, but they cannot see a nephrologist, and you have to manage their medications. So I think I was very grateful that I had internal medicine experience.
Yeah, thank you, Dr. Saini. That's amazing to think about. I also lived on the Eastern Shore, and that's also what inspired me to go into medicine. But yeah, for sure, there's so many there's transportation barriers. A lot of people would not want to, make that trip from the bridge. That like a lot of people I met had never been to like across the bridge, had never been to DC, even though they live about an hour and a
Yeah.
half from there. Especially Cambridge, it's considered a medically underserved area. In fact, there's one statistic that says that 1/4 of Americans are seeing nurse practitioners because there aren't enough primary care physicians available. So speaking of challenges, like what do you think was the hardest part of your journey to get to where you are, and what do you think that we should look out for as future doctors or future internists?
I think the hardest part for me probably was that during my medicine career in when I was in my medical university I was studying, the hardest part was the folks who were practicing in US at the time, and I will ask them questions, and they would not be that inspiring. On the contrary, some of them will tell me horrible stories, and kind of like leg pulling in a way. That was the hardest part that I sometimes would take that back, and I will sit and I'll say, can I even do this? You will meet along your journey a lot of folks who can pull you down, who can say you probably cannot do this. But it's always the challenge, and it's always pulling up from that and saying, yes, why, how come this person can do it and I cannot? So don't let anybody tell you what you can or cannot do. Just put your mind to this, and you're definitely going to be successful. I think in my case, the most difficult part was there were certain seniors of mine, even in my own med school, and I will ask them, they were doing residencies in US, and I would happen to run into them once, and I asked them questions about how the residency system is in US. And I was so, I was still finishing up my med school. Some of them will say, that's a very big, far fetched dream. Don't even think about it. It's very hard. So don't let anybody say that something is very hard. Do your own work. You guys are much more smarter than where I was back in 2009. There was not that much social media. You guys have so many avenues, especially with teleshadowing also. There's so many avenues to reach to attendees, to reach to clinical practitioners, doctors like me, that you can ask questions, and we can help and support you. And you have so many means to use it to your advantage, that I don't think there should be anything hard. The only hardest part is making the decision in your mind here that, yes, I need to be something in my life. That's all. Once you have that determination, you will do whatever you can.
Thank you, Dr. Saini. You're so right. I feel like IMGs are often very discouraged from
Yeah.
pursuing their dreams. So I really appreciate you saying that. I think our listeners will appreciate that as well. And actually, like speaking of success, like what skills are the most important for a successful career in internal medicine?
I think the most important is being humble. You need to be very, very, very humble. Learn everything from every day of your life. Be humble, be polite to your attendees. Very important tip in residency. Don't have that egoistic attitude. Don't come into this career with a very big ego, very big attitude. You're not going to succeed. But just be humble and polite to your patients, and to your attendees. I am going to tell you, by default, if somebody going to irritate me, my answer is I have patients who irritate me, or I have patients who will ask me 30 times narcotics and stuff. There are scenarios that can uptake you, that can irritate you and stuff. That's different. But the most important thing is just be very humble, have your ears open and eyes open, and listen to the advice of your peers and your attendees. They are here to help you, support you during your career, and they just get as much grateful, and they feel very happy when you succeed. All of my attendees now, where I am, when I tell them, I did this, I meet them during conferences, they feel so proud. So always learn from your attendee and be humble.
Thank you, Dr. Saini. I think that reminds me of an analogy my mom once told me is the more apples a tree has, the more it is more down to earth, more
Yep.
humble. So the more blessings you have, the more degrees you get, the more money you have. I think it
Yeah.
is so important to be humble. And I really appreciate that reminder. Thank you so much.
Yeah, especially in US. With me, when I was practicing, I was doing residency. There were my own batchmates from India and Pakistan, and you will learn from. Not everybody has behavior or habits like that, but some of them will got their residencies got stopped and they got rusticated during this time period, which was quite sad. But then you learn what happened, why was that done, And it is always about your behavior piece. Um, when somebody is giving you advice and they are at a mentorship level or at an attendee level, just listen and have your head down. Of course, fill it up with a lot of education, with a lot of wisdom. By having your neck down doesn't mean you're going to bow to anybody, but it's just that you have so much wisdom. So that is the piece of advice I would say to everybody.
Thank you, Dr. Saini. That actually answered our other question we had, like what advice do you have? But you already answered that for us. And our next question is, how do you manage your work-life balance? You're so busy, you're involved in so many different places. So how do you manage your work-life balance with your family and work?
I think sometimes I'm surprised too, but you become a pro after 2, 3 years. You will become a pro into your practice because fresh out of residency, it's going to take you 1 or 2 years. And MGMA standard says it takes about 2 years for a physician to come to that 50% mark of to be that much productive for a practice. So it's going to take 2 years for you to learn your flow and to learn how you are in the primary care, to learn yourself, what you do with your patients, how often you can finish your notes on time, and so forth. I'm not going to lie. The first 2 years, I had my daughter, and I still do not even recall how soon the time went by. And my daughter was like 3 months, and I went into going back into the practice. The times were challenging. I was not able to finish my notes on time and so forth. But slowly by slowly, you will develop your flow. It's all about time management. It's all about taking your time on a weekend. You want to enjoy your life also, so take a day, 2 days to enjoy. But at the same time, for me as a woman, I have other duties too. I have to cook, I have to take care of the kids on the weekends too, run their errands. So it's all about time management. Be very wise about your time. And if you especially have family, you have responsibilities to them. So just manage your time judiciously.
Dr. Saini, you're honestly a superhero. So thank you so much for sharing. And I guess our last question is, what are some resources you recommend for students who are interested in pursuing internal medicine and becoming like you when they grow up?
The resources would be, you guys are a very big resource here, teleshadowing. Of course, there is American College of Physician has a lot of resources listed on their website for internal medicine. They also have a book actually. I do not know the title. I can definitely send you in the email. My career in medicine, and it's a book about a guy, why he pursue a career in internal medicine, and he's a doctor, and he's talking about that. Another good book, I again I'm lacking on the title of it, that I read early on was a doctor who was practicing on Maine, in Maine actually, and he will practice on the mainland for Maine in Portland, and he has a boat, and he will take it to the small islands, and he will visit all his patients there. That was also very inspiring. So some good inspirational books, but at the same time, American College of Physicians has a good database um, to help you guys with the internal medicine career.
Thank you so much, Dr. Sini. We'll definitely link the ACP resources, and I'll find the books. I think I've read the one about in Maine, so I'll also include that in our email. So thank you so much, Dr. Sini. We really appreciate you taking the time to answer all of our questions today and taking the time out of your day, out of your precious day, to mentor us. So inspired by you speak so many languages, so we wanted to make a thank you slide with all the languages as
Oh,
well.
thanks a lot. That's very kind of you.
Thank you. And I'd love everyone to please give a warm thank you to Dr. Sini in the chat box for this incredibly informative session. Thank you.
Yeah, please feel free to reach out to me if you guys have any question through Minahil. And thanks, Minahil. You are a superhero yourself. I'm amazed that even in med school, you can do all these extracurricular activities that you're doing. Not only you're helping yourself, but you're helping so many kids sitting in different parts of the world through this very big and important portal of teleshadowing. You are a superhero. You are somebody that I look up to actually. Even now into my internal medicine career, I'm amazed actually by you. So thanks a lot for being who you are. And I'm really glad that I met you, and I'm so grateful to you.
Thank you, Dr. Saini. That means a lot coming from you and as my role model. Now we're going to conduct our closing session with our quiz and their future session dates. So the link to the quiz for the session is now live. As always, you'll need a 70% or higher to pass and receive certification for our students here. Our next session will be next Saturday, January 4th. We'll be doing occupational medicine, which is also a subspecialty of preventive medicine and also internal medicine. So we're looking forward to seeing all of you at our upcoming sessions. And this concludes this week's shadowing session. Thank you. Take care. Bye.
Take care. Bye.